And do medical ethics in America, are they the same as the medical ethics in China or India or Africa? And you can see that value systems change from place to place. And what happens when somebody from India is visiting America, and by my standards, I think that such and such that should be done, but the person says, in India, we don't do things that way. And what if we say, well, we don't think that's right, and this is how we do it here? Which way do you choose? I'll give you an example that we see not infrequently. We see people, and it's not necessarily people from other countries, although it is often the case, when a person comes, an elderly person, and has a diagnosis of cancer, and the children say, don't tell mom that she has cancer, or don't tell my father. And we say here in America, well, we're very open about this, and we believe in informed consent and telling people what's wrong with them. And people say, no, we don't do that from where we come from, or that wasn't the practice, or if we tell my mother, she'll be so devastated she won't want to live anymore. But how can we give her chemotherapy, or how can we do an operation without telling her? So you see that these cultural differences can often be very relevant to the types of problems and the types of medicine that we practice on a day-by-day basis. So I hope that I have tickled your appetite for some of the medical ethical issues. And now I'd like to present you a couple of real cases that we had up at Columbia. And maybe I'll ask some of you to give me your thoughts as to, you're on the ethics committee now, and I'm coming to you and asking you for your opinion. You're the ethicist. And I'd like to hear what some of you might think. The first case that I'll tell you about was the case of a homeless man who was brought into Columbia by the police because he was found outside of a subway station in Manhattan, and he seemed to be in pain, and he was all disheveled and obviously not totally with it. And he was brought to our emergency room, and he was admitted to the hospital, and he had had some intestinal bleeding, and we quickly took care of that. He stopped bleeding, he got some blood, but then it was realized after he was in the hospital for a few days that he was blind. He couldn't see anything. And when we spoke to the man, and the reason that he was blind is because he had what are called cataracts. Now, cataracts are extremely common. If those of you who may have taken biology and know about the eye know that there is a lens that is right behind your iris, the black part of your eye, which tends to focus the rays on the retina. And the lens, in people as they get older, the lens in many people becomes cloudy. Normally the lens is as clear as water, or as a clean piece of glass. And because the proteins that comprise the lens degenerate with time, it becomes foggy, and it looks as if you're looking through a piece of smoked glass. And the greater and denser the cataract becomes, the more the person is deprived of sight, until a person may reach the point where they are blind, they cannot see. The nice thing about cataracts, it's one of the most beautiful things. You can take out the cataract today, you can substitute a plastic lens that goes right into the lens capsule, and the person can see as good as new. And so here was a man who had a totally reversible cause of blindness. When we spoke to this man, he really was very fuzzy. He gave us his name, but we tried to check out his identification, and all of the leads that he gave us turned out to be nothing. We had no idea who he was, how old he was, anything about his family. He told us that he had a wife and children. He even told us the high school he went to. We checked with the high school for their records. They had another person by that name. We called the person up. He never heard of this man, and so it was a little bit of a detective story. The problem is, we said to him, and I can tell you, he said his name was Norman Smith. There's no violation of the HIPAA code because that wasn't his name. So Norman said, we said, we would like to take your cataracts out. We will make you able to see once again. And he said, no. And he said, why? And he would just mumble, can't see, no, I'm afraid. And we had the neurologist see him, and we had the psychiatrist see him. What is wrong with this man's mind? We came to the conclusion that he probably had some degree of schizophrenia, which is a very serious mental illness, and he clearly was having some delusions about where he was, his age. He said he was much younger than he really looked. And so, but he was refusing to have the cataract operation. But when we said, Norman, if we could put you to sleep, if you went to sleep and you woke up one day and you could see again, would you be happy? And he said, sure. So Norman wanted to see, but he didn't want us to take his cataracts out. He didn't want the operation. What do you do in a situation like that? And all he did, this was not a normal person who was blind, because normal blind people will learn Braille, they will listen to books, they will try to get around, they'll get a seeing eye dog, they'll try to have a life of themselves. All Norman did was lie in bed. He was afraid to move because he couldn't see. He couldn't cope with his blindness because of the psychiatric problem. So we had at our finger. Now you may say, well, what are the risks of doing a cataract operation? The risks are very trivial. It's about a 15-minute procedure. It's done, normally it's done under local anesthesia where you put drops in the eye to numb them up. And in 15 minutes, you have the new lens, you have to put some drops in the eye afterwards. It's a fantastic miracle of modern science. I mean, you can't die from a cataract operation. The problem is that if we were to force Norman against his wishes to have the operation, we would have to put him to sleep because he wouldn't cooperate, because he didn't want it, he was afraid. And so the risk would be higher for him. Anytime you give somebody general anesthesia, there is a very small risk that they could have some serious problems. But I'll bet there are people amongst you here who've had general anesthesia. You all look very healthy. You've come through it okay. The risk for a healthy person is extremely small. So no rational person would ever say, no, I would rather be blind than have my cataracts out, if they truly understood what was involved. So the ethical question was, and we were called, do we take Norman's cataract out against his wishes, because we think that this is the principle of beneficence, so-called in medical ethics, where we do good for patients, beneficence. On the other hand, there's a principle of autonomy, which says that the patient is the boss. But is the patient also the boss when the patient is not quite with it, when the patient is being irrational? Well, let me ask you folks a question. You're now on the ethics committee, and this is what they're asking you. What do? Do we send him to a nursing home and leave him blind, or do we take him against his wishes to have his cataract out? Does anybody have any ethics? And one thing, you have to speak up loudly, because I do not hear well, so speak at the top of your voice. Yes, ma'am.
What I would do if I was y'all, give him some antipsychotics, like some schizophrenia drugs, to see if he became rational to make a good decision.
Excellent decision. You have to sign up for our psychiatry program. No, that was a very good decision, very good, and we did give him antipsychotic medications. We did exactly what you recommended, but it didn't help. But that's an excellent. Now, implicit in what you're saying is that we can fix all psychotic people with the right medication. Unfortunately, antipsychotic medication is good for a lot of people, but it doesn't work for everybody. And he was chronic schizophrenic. We tried him, the psychiatrist saw him, we waited for weeks. They tried tweaking the medications, and it really made no significant impact. But that's an excellent suggestion. Yes, ma'am?
I think that he probably should, because it sounds more like he has a fear of seeing. But at one point you did mention that he said that he would be happy. So it sounds more like a casual fear, like if someone's afraid of a dog.
Mm-hmm.
So after a while, if he is able to see, and he says that before that he's happy, after a while you get accustomed to it, so it should not be a problem.
Okay, that's an interesting point. Actually, we didn't think that he had a fear of seeing. We felt that his fear was of the procedure necessary to get him to see. Which, although, given the fact that he was psychotic, it did occur to us, what if we took him to have the operation and he could see, is it conceivable that somebody in his state of mind might be miserable seeing and would have been happy or not? That thought crossed our minds. That did cross our minds. But to the best of our ability to analyze what he wanted, it was the fear of what he needed to go through in order to be able to see rather than of the sight itself.